Welcome to the module on transposition of great arteries in the Echo textbook of Congenital Heart Diseases. Transposition of great arteries is one of the commonest cyanotic diseases which presents in neonatal period. The characteristic feature of transposition of great arteries is ventricular arterial discordance, which means aorta originating from the morphological right ventricle and pulmonary artery originating from the morphological left ventricle. There should be a pulmonary mitral fibrous continuity. In transposition of great arteries, the systemic venous blood returns back into the aorta and the pulmonary venous blood returns back into the pulmonary artery. This results in parallel circulation. The oxygenation of the systemic arterial blood will totally be dependent on the sites of intercirculatory mixing. The intercirculatory mixing can be intracardiac at atrial septal or ventricular septal level, or extracardiac at the level of ductus arteriosus or bronchopulmonary collaterals. The time at which a newborn baby presents with transposition of great arteries will depend on the adequacy of the atrial septal communication, whether there is a ventricular septal defect or a patent ductus arteriosus, whether there is an arch obstruction. If there is a transposition with intact ventricular septum, usually a newborn presents with severe hypoxia. However, if there is a large VSD or a large PDA, the clinical presentation will be delayed for a few weeks. However, all patients with transposition of great arteries have an uniformly poor natural history if no surgical intervention is done. Transposition is classified as simple transposition of great arteries if it is associated with either intact ventricular septum or a very small restrictive ventricular septal defects. It is referred to as complex transposition of great arteries if it is associated with large ventricular septal defect, right or left ventricular outflow tract obstructions, or large PDA and arch obstructions. When we assess a simple transposition of great arteries with echocardiogram, we should pay attention to the intratrial septal communication, presence or absence of a restrictive ventricular septal defect, the relationship of the great arteries, the presence of dynamic left ventricular outflow tract obstruction, and the pattern of coronary arteries. Ventricular arterial discordance is the characteristic feature of transposition of great arteries. In this apical view, we identify that the left ventricle is giving off a posterior vessel which bifurcates, and this is the pulmonary artery, and the right ventricle gives off an anterior vessel which ascends subsuperiorly as the ascending aorta. This origin of pulmonary artery from the left ventricle and aorta from the right ventricle is the hallmark of transposition of great arteries. On a color Doppler interrogation from the apical view, we can appreciate that the blood vessel that is arising posteriorly from the left ventricle is bifurcating, and the blood vessel that is arising from the right ventricle anteriorly is not bifurcating. A transposition is described as a simple TGA if the interventricular septum is intact, a very restrictive small membranous or muscular VSD, even if it is present, it will not alter the hemodynamics much, and so they are also referred to as simple transposition of great arteries. In transposition, the outflows of both the left ventricle and right ventricle are parallel. We can notice the right ventricle giving origin to the ascending aorta and left ventricle giving origin to the main pulmonary artery. Both the aorta and the main pulmonary artery are coursing parallel to each other. On a parasternal long axis view, once again these parallel outflow tracts are clearly visualized. The anterior right ventricle gives off the ascending aorta. The posterior left ventricle gives off the pulmonary artery. We can notice that the anterior mitral leaflet and the pulmonary annulus are in contact with each other. This is defined as the pulmonary mitral fibrous continuity. We can also notice that the right ventricular free wall is very thick. The right ventricle supports the systemic circulation and right ventricular hypertrophy is the rule. Both the great vessels, aorta and pulmonary artery, have got a parallel course. On this parasternal long axis view, we can identify the entire cavity of the right and left ventricle. The right ventricular free wall is thickened, indicative of right ventricular hypertrophy. The aortic valve and the pulmonary valve are seen. The aortic valve is anterior and pulmonary valve is posterior. In a simple transposition of great arteries, in the early neonatal period, the pulmonary annulus and the main pulmonary artery may sometimes look smaller than the aortic valve and the ascending aorta. When we magnify on to the origin of the great arteries, we can notice that the aortic valve and the ascending aorta are anterior. The pulmonary valve and main pulmonary artery are posterior. This magnified view also shows the pulmonary mitral fibrous continuity. Anterior mitral leaflet has got its annular attachment in very close proximity to the pulmonary annulus, and this is called as the pulmonary mitral fibrous continuity. We can also notice that the aortic valve is located more cranially due to the presence of a subaortic conus or a subaortic infundibulum. Identifying the fibrous continuity between the annulus of the mitral valve and the annulus of the pulmonary valve is important in the diagnosis of transposition of great arteries. The transposition of great arteries is characteristically associated with pulmonary mitral fibrous continuity. We can notice that the anterior aorta is marginally larger than the posterior pulmonary artery. This is usually seen in many of the transposition of great arteries in early infancy. Color Doppler interrogation shows unobstructed flows from the right ventricle into the ascending aorta and from the left ventricle into the pulmonary artery. Most of the complex transposition of great arteries associated with large ventricular septal defects and pulmonary hypertension will have markedly dilated pulmonary annulus and main pulmonary artery. However, in simple transposition of great arteries presenting in early neonatal period, the pulmonary artery may be anatomically smaller than the ascending aorta. On a subxiphoid short axis view, we can identify the right ventricle and the left ventricle, giving origin to the ascending aorta and main pulmonary artery. The interventricular septum, which is intact, is bowing towards the left ventricle because the left ventricular systolic pressures are lower than the right ventricular systolic pressures. The right ventricular systolic pressure will be systemic pressure, whereas the left ventricular systolic pressure will be subsystemic. In a simple transposition on subxiphoid short axis view, we can notice the anterior right ventricle giving off the anterior aorta, the posterior left ventricle giving off the posterior pulmonary artery. The pulmonary annulus and the main pulmonary artery are marginally smaller than the aortic valve and the ascending aorta. The interventricular septum is intact and the interventricular septum bows towards the left ventricle because the left ventricular systolic pressure is subsystemic. On a magnified subxiphoid view, we can notice the parallel outflow tracts originating from the right ventricle and left ventricle. The anterior great artery is the ascending aorta and the posterior great artery is the main pulmonary artery. On color Doppler view from subxiphoid short axis, we can notice the parallel great artery relationship. The ascending aorta and the main pulmonary artery courses parallel to each other. They do not cross over. Adequacy of intratrial communication is very important for maintaining the oxygen saturations in a patient with transposition of great arteries. The intratrial communication will be in the form of a patent foramen ovale. If the intracirculatory mixing is adequate, very severe hypoxia will not be present in early neonatal period. However, if the foramen ovale is very restrictive, it may result in life-threatening critical hypoxia in patients with simple transposition of great arteries. In this subxiphoid short axis view that shows the intratrial septum, we can notice the superior vena cava entering into the right atrium. There is a very restrictive foramen ovale. The PFO is causing a small color jet from the left atrium into the right atrium. This restrictive patent foramen ovale will result in inadequate intracirculatory mixing and so makes the newborn baby present with critical hypoxia. The quantum of blood that is flowing from the left atrium into the right atrium will be the effective systemic cardiac output. The quantum of blood flow that is coursing from the right atrium into the left atrium will be the effective pulmonary outflow. If the patent foramen ovale is very restrictive, the amount of shunt through the foramen ovale will be very small, and this will mean very reduced effective cardiac output and effective pulmonary blood flow. On a magnified view of the intratrial septum, we can notice an extremely restrictive foramen ovale. However, in this example shown from the subxiphoid coronal view, we can notice a large atrial septal defect with good interatrial mixing. We can see the bidirectional flow through the large ASD. In this subxiphoid short axis view, again we notice a large atrial septal defect. When there is a large atrial communication, the intracirculatory mixing will be very adequate. Simple transposition of great arteries is defined as TGA with either intact ventricular septum or very tiny ventricular septal defects. In transposition with intact ventricular septum, the position of the intraventricular septum is an useful indicator of the left ventricular systolic pressure. This adequacy of left ventricle as decided by the left ventricular systolic pressure is very important in performance of arterial switch operation. If the left ventricular systolic pressure is very low, the left ventricular hypertrophy regresses and the left ventricular free wall gets thinned out. And such left ventricles will need retraining before an arterial switch operation. Sometimes the ventricular septum may bow into the left ventricle and cause a dynamic left ventricular outflow tract obstruction or subvalvular pulmonary stenosis. In this subxiphoid short axis view, we can notice that the intraventricular septum is bowing into the left ventricle in systole, and this is an indicator of subsystemic left ventricular systolic pressures. We should also look at the left ventricular free wall thickness in the end of diastole. In end diastole, when the left ventricle fully relaxes and the left ventricular cavity is fully open, we can appreciate that the left ventricular free wall thickness is much smaller than the right ventricular free wall thickness. The right ventricular free wall is obviously hypertrophied since it sustains the systemic circulation. The bowing of the intraventricular septum towards the left ventricular cavity in end systole is the hallmark of subsystemic left ventricular systolic pressures. In an apical four-chamber view, again the position of the intraventricular septum will be of great use in identifying the adequacy of the left ventricle and a rough estimate about the left ventricular systolic pressures. In this example of an apical four-chamber view of a patient with transposition of great arteries, the intraventricular septum does not bow significantly towards the left ventricular cavity. This may be an indicator of the left ventricle having pressures very close to the right ventricular systolic pressure. The patient shown in the previous example is now interrogated from the subxiphoid view. On subxiphoid short axis, we find the right and the left ventricle. The left ventricular cavity is fairly adequate and the intraventricular septum is more or less perpendicular. The intraventricular septum does not bow significantly into the left ventricle. And this is an indicator of near systemic left ventricular systolic pressures. This will indicate that the left ventricle is fully adequate for performance of an arterial switch operation. So far, we had seen in a simple transposition of great arteries the evaluation of the interatrial communication and the interventricular septal profile. Now we move on to the great artery relationship in transposition of great arteries. Right and anterior aorta is the most common great artery relation. Sometimes the great vessels can directly be anteroposterior with an anterior aorta and a posterior pulmonary artery. In few patients, it may be left malpost aorta, that means left and anterior aorta and right and posterior PA. It's very rare to have a normal origin of great arteries in transposition of great arteries. The parasternal short axis view is the best view to evaluate the relationship of the great arteries. Here the aortic annulus is right and anterior to the pulmonary annulus. We can notice the trileaflet aortic valve and a trileaflet pulmonic valve. The aortic annulus and the aortic root is marginally larger than the pulmonary annulus and the pulmonary root. This is commonly seen in newborn babies with simple TGA. The relationship of the great artery of right and anterior aorta, left and posterior pulmonary artery is the commonest great artery relationship in simple transposition of great arteries. The relationship of the great arteries should be defined at the level of the sinuses. On a parasternal short axis view, at the level of sinuses, we will be able to identify the leaflets of the aortic and pulmonary valves. We can see the ascending aorta lying right and anterior to the pulmonary root, and both the aortic valve and pulmonary valve are trileaflet. We can notice the left atrial appendage to the left of both the great arteries. Sometimes the ascending aorta may directly be anterior to the pulmonary root, This will be described as the anteroposterior great arteries. The ascending aorta is anterior and the pulmonary artery is posterior. Once again notice that in simple transposition of great arteries in early neonatal period, the pulmonary annulus and the pulmonary root may marginally be smaller than the aortic annulus and the aortic root. In some of the TGA, the aortic root can be left and anterior to the pulmonary artery. This will be called as the L post aorta or L mal post aorta. When one of the great artery is left and anterior to the other great artery, sometimes the anterior blood vessel may be confused as the pulmonary artery and the posterior blood vessel may be confused as the aorta. In normal relationship of the great artery, the pulmonary artery is left and anterior and the aorta is right and posterior. When we see two blood vessels, one of them lying left and anterior to the other, we should carefully look at the coronary origin. Here in this example, we can identify that the coronary arteries are originating from the vessel which is left and anterior. So we know that the aorta is left and anterior to the main pulmonary artery. It is very extremely rare to find the normally related great artery in a patient with transposition of great arteries. In this patient with TGA, with ventricular arterial discordance, we see a normally related great artery. The pulmonary artery and the pulmonic valve is left and anterior. The aortic root and the ascending aorta are right and posterior. This normal relationship of the great artery is extremely rare in TGA. Rarely we can see side-by-side great artery relationship. We can see the ascending aorta lying to the right of the pulmonary root in this example. We can notice that the ascending aorta is giving off the coronary arteries. The pulmonary artery is to the left side and the aortic root is to the right side. This side-by-side great artery relationship is also relatively rare in transposition of great arteries. Whenever there is a side-by-side great artery relationship in TGA, very often the aortic root will be on the right side and the pulmonary root will be on the left side. However, in extremely rare examples, the aortic root can be on the left and pulmonary root can be on the right. This is an example of an extremely unusual great artery relationship where there is a side-by-side great artery. The aortic root is shown in the center of this magnified view, giving off the coronary arteries. And we can notice that the pulmonary root is located to the right and the aortic root is located to the left. A side-by-side great artery relationship with aorta to the left of the pulmonary artery is extremely unusual in TGA. Now we move on to assessment of the left ventricle's adequacy in a simple TGA presenting with intact ventricular septum. If the left ventricle is adequate, these patients can be taken up for corrective arterial switch operation. If the left ventricle has totally regressed, then performance of arterial switch operation will be difficult since the regressed left ventricle may not be able to sustain the high systemic vascular resistance and to sustain the systemic circulation. We should first know what is left ventricular adequacy or left ventricle preparedness. Before birth, the left ventricle and right ventricle have got similar pressures and the left ventricular and right ventricular mass is fairly equal. After birth, the fetal pulmonary vascular resistance reduces. With the reduction of pulmonary vascular resistance, the pulmonary artery pressure falls. And when the pulmonary artery systolic pressure reduces, the left ventricular systolic pressure also reduces, and the left ventricle begins to involute. As the left ventricular mass progressively reduces in relation to the body surface area, it becomes very thinned out. Such a thinned out left ventricle may not be able to pump against systemic vascular resistance and systemic pressures if we perform an arterial switch operation. This inability of the thinned out left ventricle to pump against the high systemic vascular resistance and high systemic arterial pressures is afterload mismatch. The methods used in echocardiography to identify the left ventricle preparedness is by noting the left ventricular free wall thickness, calculating the left ventricular mass, assessing the left ventricular mass to volume ratio, looking at the left ventricular shape, looking at the interventricular septal configuration on a short axis view of the left ventricle, and if there is a mitral regurgitation jet, to assess the left ventricular systolic pressure, and finding out the left ventricular systolic pressure to right ventricular systolic pressure ratio. Left ventricular free wall thickness is assessed in areas which are free of papillary muscles. The left ventricle is assessed in the end diastolic frame. We need to scroll the image and get at the end diastolic frame where the left ventricle becomes very, very thinned out, and then take the measurement in an area which is devoid of the papillary muscle. One of the methods to identify the left ventricular free wall thickness in the end of diastole will be to use the M mode. In M mode, we can very easily identify the systolic and diastolic phases of cardiac cycle, and we can notice the end diastolic frame and take the thickness of the LV posterior wall in end diastolic frame. Whenever the left ventricular free wall thickness is less than 4 mm, it is of concern. The left ventricular mass is calculated by tracking the epicardial and endocardial border of the left ventricle in short axis view at the level of the papillary muscles, and then seeing the length of the left ventricle in the apical 4-chamber view, and the machine can automatically calculate the mass based on the formula. A left ventricular mass indexed to body surface area of less than 35 grams per meter squared body surface area is considered a regressed left ventricle and usually cannot sustain systemic circulation after an arterial switch operation. The left ventricle mass is then compared to the left ventricular end diastolic volumes. If the left ventricle mass to volume ratio is less than 2.5 gram per ml, once again it is of concern. The left ventricular end diastolic volume is calculated by the modified Simpson's method from apical 4-chamber view. One of the methods used for assessing the left ventricular adequacy is to identify the shape of the left ventricle. In this apical 4-chamber view, we identify the right ventricle to be dilated. The right ventricular systolic contractility is marginally reduced. The right ventricle free wall is very thick. The left ventricle appears to be squashed to one of the corners. The interventricular septum is bowing into the left ventricle in systole. This is an indicator of a regressed left ventricle. On the short axis view, when we look at the interventricular septal position, we notice that there is a bowing of the interventricular septum in end of systole, and this is also an indicator of regression of the left ventricle. All the indicators described above, namely the left ventricle free wall thickness, the left ventricular mass, the left ventricular mass to volume ratio, the shape of the left ventricle, the position of the intraventricular septum are all taken into consideration before deciding on the adequacy of preparedness of the left ventricle. When the volume of the left ventricle is large, this is often seen in patients with very restrictive foramen vein, the shape of the left ventricle may be preserved, but the mass and the free wall thickness will be very low. On the example that is shown on the right hand of the screen, the left ventricular cavity looks very big. However, the left ventricle free wall thickness is very reduced in comparison to the right ventricular free wall thickness. So all these parameters should be factored in before we decide on the adequacy of the left ventricle. On a subxifoid short axis view, we can notice the significant bowing of the intraventricular septum towards the left ventricle in end of systole, indicating the left ventricular systolic pressure is much lower than the right ventricular systolic pressure. On a parasternal long axis view, a regressed left ventricle will be squashed to one corner by the dilated right ventricle. We can see that the left ventricular cavity is extremely small and the left ventricle is squashed to one of the corners. In this example, even though the intraventricular septum is not significantly bowing into the left ventricle, we can notice that the left ventricular free wall thickness, especially in the end of diastole, is very small. We need to compare the left ventricular free wall thickness in end diastole against the right ventricular free wall thickness or the intraventricular septum. When we take a short axis view of the right and left ventricle in extremely apical areas, we will not be able to identify the bowing of the intraventricular septum into the left ventricle. We need to identify the bowing of the intraventricular septum into the left ventricle in more mid and basal areas of the left ventricle. This is an example of an apical view of a left ventricle which is partially regressing. We can notice that the left ventricular cavity is smaller than the right ventricular cavity. However, the intraventricular septum is not totally bowing into the left ventricle, and the left ventricular free wall thickness is comparable to the intraventricular septum and right ventricular free wall thickness. TGA could be associated with presence of ventricular septal defect in almost about 50% of the patients. The ventricular septal defect could be very restrictive and hemodynamically not lead to any substantial right ventricle to left ventricle shunt. In such cases, it is often equated along with patients with simple transposition of great arteries. However, in some patients, the ventricular septal defect can be very large. The location of the ventricular septal defect could be anywhere in the ventricular septum. In this apical view, we are able to appreciate a restrictive perimembranous ventricular septal defect. The ventricular septal defect is in close relation to the anteroseptal tricuspid commissure. You can also notice that there is a left juxtaposition of the atrial appendage. The right atrial appendage gets elongated posterior to the great arteries and reaches up to the left atrial border, and this is what is called as the right atrial appendage left juxtaposition. The same restrictive perimembranous ventricular septal defect is shown on a subxifoid view. We can notice the extremely close relationship between the small ventricular septal defect in the membranous septum and the tricuspid valve leaflets. The ventricular septum, the defect in the ventricular septum directs the jet from the right ventricle into the left ventricle in the subpulmonic area. Contrary to the previous example of the perimembranous ventricular septal defect which was located immediately below the pulmonic valve. Here we can notice a ventricular septal defect that has got a thick muscular margin from the pulmonary and aortic annulus. So this is an example of a high muscular ventricular septal defect. We can notice the parallel great artery relationship, the aorta arising from the right ventricle and the pulmonary artery arising from the left ventricle. In the previous example shown with a high muscular ventricular septal defect, we can notice the color flows through the high muscular VSD. Since the left ventricle and right ventricle pressures are similar due to the large ventricular septal defect, the flows across the ventricular septal defect are very laminar and do not show any turbulence. Sometimes the muscular ventricular septal defects in transposition of great arteries can be multiple, small and located in the apical portions of the interventricular septum. In the subxifoid short axis view, we can notice multiple small color jets with blue color shunting from right ventricle to left ventricle. In this apical four-chamber view, we can notice the multiple small ventricular septal defects in the apical portion of the interventricular septum. This is an example of a restrictive midmuscular ventricular septal defect. We can notice the turbulence on the left ventricular side of the interventricular septum due to restrictive nature of this ventricular septal defect. From the pasternal long axis view, the restrictive muscular ventricular septal defect is shown immediately below the moderator band. We can notice that in most of the patients where there is a ventricular septal defect, the left ventricle is adequately prepared, the left ventricle cavity is well developed, and the left ventricular free wall thickness is also adequate. Some of the muscular apical ventricular septal defect may be like a Swiss cheese defect. There will be multiple interventricular communications all along the apical portion of the ventricular septum. Large conotruncal subarterial VSDs are also very common in transposition of great arteries. In this parasternal long axis view, we can notice that there is a very large subpulmonary VSD. In the initial frames, we can see that the pulmonary annulus overrides the ventricular septal defect. Around 50% of the pulmonary annulus is committed to the left ventricle and another 50% of the pulmonary annulus is committed to the right ventricle. And on a further sweep, we can notice the aorta originating from the right ventricle. The point of differentiation between a double outlet right ventricle with a subpulmonary VSD and a transposition of great arteries with a large subpulmonary VSD will be by noting the presence or absence of pulmonary mitral fibrous continuity. If the pulmonary annulus is in fibrous continuity with the mitral annulus, and if there is a point of contact between the pulmonary annulus and the anterior mitral leaflet, then they are defined as TGA with large subpulmonary VSDs. If there is a fibrous discontinuity between the pulmonary annulus and the mitral annulus, and a subpulmonary conus is documented, then they are defined as double outlet right ventricle with subpulmonary VSD, which is also called as Taussig Bing anomaly. Another example of a large conotruncal subpulmonary VSD seen from the apical view. We can notice the pulmonary annulus in fibrous continuity with the mitral annulus. The pulmonary annulus is smaller and there is a large subpulmonary VSD. The conal septum between the aortic and the pulmonary annulus is posteriorly deviated towards the subpulmonary outflow tract, causing a narrowing of the subpulmonary outflow tract. This posterior malalignment of the conal septum as against the trabecular interventricular septum causes a malaligned VSD. When the conotruncal subpulmonary ventricular septal defects are very large, the pulmonary annulus may appear to significantly override the ventricular septal defect. In this example, almost about 70% of the pulmonary annulus is committed to the right ventricle. However, there is a very clear pulmonary mitral fibrous continuity. So this will still be defined as a transposition of great arteries with large subpulmonary ventricular septal defect and pulmonary artery override into the right ventricle. The pulmonary override can also be appreciated from subxiphoid short axis views. In this example of a large subpulmonary ventricular septal defect, there is a 50% override of the pulmonary annulus towards the right ventricle. However, there is a very clear pulmonary mitral fibrous continuity. Very often, a large perimembranous ventricular septal defect in a transposition of great arteries will be abutting the pulmonary annulus. However, in some patients, there can be a small region of conal septum that is separating off the ventricular septal defect margins from the pulmonary annulus. This is an example of a large perimembranous VSD which is located in close relation to the anteroseptal tricuspid commissure, however, is separated from the pulmonary annulus by a small conal septum. In all patients with transposition of great arteries, it is important to document the pulmonary mitral fibrous continuity. Another post-tricuspid intracirculatory mixing seen common in transposition of great arteries is patent ductus arteriosus. In this example, on parasternal long axis, we can notice the aorta originating from the right ventricle, the pulmonary artery originating from the left ventricle, and both of them have got a parallel outflow tract. The aorta is anterior and the pulmonary artery is posterior. We can notice that there is a continuous flow into the pulmonary artery from a restrictive ductus arteriosus. The ductus arteriosus can also be seen from the suprasternal view. We can notice the left aortic arch, a very long tubular PDA inserting into the main pulmonary artery. The pulmonary artery and the ductus are comparable in their size, and the ductus is very large. When the ductus is very large, as in these cases, there won't be much of pressure differences between the aorta and the pulmonary artery. We can notice that the flow in the ductus is very laminar and not turbulent, indicative of similar pressures in the aorta and pulmonary artery. A Doppler across the ductal flows indicate that the velocities are less than 2 meters per second, indicative of nearly same pressures between the aorta and pulmonary artery. When surgical treatment is delayed in patients with transposition of great arteries and large patent ductus arteriosus, eventually the pulmonary vascular resistance gets increased. Then we will notice that there is a pulmonary artery to aortic flow across this ductus. In other words, a flow reversal across this ductus. In this example, we can notice a large ductus. The flow is entirely right to left from the pulmonary artery into the descending thoracic aorta. This is an indicator of PDA with very high pulmonary vascular resistance. When transposition of great arteries is associated with a large PDA, the pulmonary artery pressures will be maintained at equal levels to the systemic pressures, and so the left ventricle will be very adequate. The left ventricle free wall thickness is significantly higher, and the left ventricle will be considered adequate for performance of an arterial switch operation. A parasternal long axis view of a patient with a large patent ductus arteriosus shows a good thick left ventricle. We can compare the left ventricular free wall thickness with the right ventricular anterior free wall thickness and find that both are more or less similar. On parasternal short axis view also, we can notice the significant thickening of the left ventricular free wall due to the presence of a large patent ductus arteriosus. The large PDA maintains the pulmonary artery systolic pressures at systemic levels and prevents regression and involution of the left ventricular muscle. After discussion about the intratrial communication, interventricular communications and patent ductus arteriosus in TGA, now we move on to the coronary patterns in transposition of great arteries. The coronary artery origin can be extremely variable in patients with transposition of great arteries. Morphologically, all sorts of combinations of coronary arteries have been described in patients with transposition of great arteries. Echocardiographically, a large majority of them can be identified and a few may not be identified correctly. The echocardiographic classifications of the different types of coronary artery origin enlists about 9 possible patterns. The usual pattern will have a left coronary artery arising from the middle of the left and anterior facing sinus, which is called as the sinus 1. The right coronary artery arising from the middle of the right and posterior sinus, which is called as the sinus 2. This is seen in almost 2/3 of the patient with transposition of great arteries. One of the common anomalies that is seen is an origin of the circumflex from the right coronary artery, and this is seen in almost about 20% of the patients. Sometimes coronary artery can be single. The entire coronary artery can arise as a single trunk from the left sinus or the right sinus, which will represent a single left coronary artery or a single right coronary artery. In some of the patients, the coronary arteries can be inverted, which means the right coronary artery is arising from the sinus 1 and the left coronary artery is arising from the sinus 2. Some of the serious types of abnormalities in coronary arteries are intramural coronary arteries. These will pose significant problems in performance of arterial switch operation. The coronary arteries are best identified on parasternal short axis view. We can see the ascending aorta right and anterior to the pulmonary artery. The pulmonary artery is left and posterior. This is the commonest great artery relationship seen in transposition of great arteries. The two sinuses of aorta in close relation to the pulmonary annulus are called as the facing sinuses. One of the sinus is left and anterior, and that is called as the sinus 1. The other sinus is right and posterior, and that is called the sinus 2. We can identify the right coronary artery originating from the sinus 2. This is the normal right coronary artery origin in most of the patients with TGA. We can notice that the left coronary artery is arising from the left and anterior sinus. The aortic valve is trileaflet. The left coronary artery is arising from the middle of the left facing sinus. In this parasternal short axis view, we can notice that the ascending aorta is located left and anterior to the pulmonary root. We can find the normal left coronary artery origin from the middle of the left facing sinus. In the same example, we can see the left and anterior aorta. The right facing sinus gives off the right coronary artery. So this is again a normal coronary pattern in a patient with transposition of great arteries. One of the commonest anomaly is origin of the left circumflex artery from the right coronary artery. This is seen in around 20 to 25% of patients with transposition of great arteries. The left circumflex artery takes its origin from the right coronary artery, courses posterior to the pulmonary root, and emerges on the left side of the great arteries. When we are visualizing the apical view of the heart, immediately posterior to the pulmonary root, we can see a parallel track of this circumflex artery. The normal coronary artery origin, wherein the left coronary artery arises from the middle of the left facing sinus and right coronary artery arising from middle of the right facing sinus, is one of the commonest type of coronary arteries seen in around 2/3 of the patients. And in another 20% of the patients, the circumflex will take its origin from the right coronary artery. This will almost contribute to 80% of the patients with transposition of great arteries. And these coronary patterns are very benign and do not pose any major problem in coronary transfer. However, all the other varieties of coronary artery origin abnormality can pose problems in completion of an arterial switch operation. They can be single right coronary and single left coronary arteries, the inverted coronary arteries, and the intramural coronary arteries. In this parasternal short axis view, we can notice that the aorta is directly anterior to the pulmonary artery. The coronary artery is arising from the middle of the right facing sinus. It trifurcates. The left coronary artery courses anteriorly. The right coronary artery courses towards the right. This is an example of a single right coronary artery. The single right coronary artery, which arises from the right facing sinus, will give off the LCA, which will course anterior to the aorta towards the left side of the heart. The right coronary artery will continue in the right AV groove. On the contrary, this is a single left coronary artery. We can notice that the aorta is right and anterior, pulmonary artery is left and posterior. There is a single large coronary that arises from the left and anterior facing sinus, that is the sinus 1, and immediately after origin, it bifurcates into the right coronary artery and the left coronary artery. The color flow in the right coronary artery is red because it is the direction of the flow is towards the transducer. The color flow in the left coronary artery is blue because the direction of blood flow in the left coronary artery is away from the transducer. This is an example of single left coronary artery. The coronary artery origin is called inverted whenever the right coronary artery is arising from the left facing sinus. In this parasternal short axis view, the aorta is right and anterior and the pulmonary artery is left and posterior. The two facing sinuses are numbered as 1 and 2. The sinus 1 is the left and anterior facing sinus. The sinus 2 is the right and posterior facing sinus. Whenever the right coronary artery is originating from sinus 1, then it is called inverted coronary. You can notice in this example that there is a large coronary that arises from sinus 1, from the middle of the sinus, and bifurcating into 2. The rightward branch continues as the right coronary artery, and the leftward branch continues as the left anterior descending coronary artery. In this patient, we need to identify where is the circumflex artery. We can notice the circumflex artery arising from the posterior facing sinus and coursing posterior to the pulmonary root. So this is an example of an inverted coronary where the sinus 1 gives off the right coronary artery and left anterior descending coronary artery, and the sinus 2 gives off the circumflex artery. The more serious forms of coronary artery abnormalities are the intramural coronaries. The intramural coronary arteries originate from the contralateral commissure. In this example, an intramural left coronary artery originating from the right facing sinus. And then the coronary artery courses between the aorta and the pulmonary artery sinuses, takes a long interarterial course, and in this plane of the interarterial course shown by arrows, the wall of the coronary artery is shared with the wall of the aorta. Then it emerges on the left side of the aorta and bifurcates into left anterior descending coronary artery and the left circumflex artery. This is an example of an intramural left coronary artery. The entire dotted line here shows the length of the intramural course. Along the length of this intramural course, the wall of the coronary artery is shared with the adventitia of the aorta. The echocardiographic rules of identifying an intramural coronary artery is: number 1, origin of the coronary artery from the contralateral sinus. That means an intramural left coronary artery will arise from the right facing sinus, and intramural right coronary artery will arise from the left facing sinus. The second echocardiographic feature is course between the aorta and PA. Number 3, the wall of the coronary artery will be shared with the wall of the aorta, giving a railroad appearance of the coronary artery between the aortic and the pulmonary sinuses. In this color Doppler demonstration, we can notice the anterior aortic root, the posterior pulmonary root, an intramural left coronary artery, and the coronary flows are seen in the portion of the intramural left coronary artery. The entire length of the parallel track, seen as a railroad and shown with arrows, indicate the portion of the intramural left coronary artery. As we explained earlier, echocardiographic definition of an intramural coronary artery is based on 3 findings. Number 1, origin of the coronary artery from the contralateral sinus. Number 2, sharing of a wall between the coronary artery and the aortic root. And number 3, course of this intramural portion between the aortic root and the pulmonary root. We should always try to document the color flows in the intramural coronary artery. The documentation of color flows in the intramural portions of the left coronary artery will confirm that it is indeed the coronary artery and not an artifact between the aorta and the pulmonary artery. This is another example of an intramural left coronary artery in a patient who had an left and anterior aorta and right and posterior VA. Once again, you can notice that the left coronary artery is arising from the contralateral right facing sinus. It has got a short course of wall sharing between the coronary artery and the aortic sinus, and the intramural portion of the left coronary artery is between the aortic and pulmonary sinuses. On a still frame, we can appreciate that the left coronary artery's wall is shared with the aortic wall for a short segment, and this segment will be the intramural segment. Also notice the course of the intramural coronary artery between the aortic and the pulmonary sinuses. In all intramural coronary arteries, the wall of the coronary artery is shared with the aortic wall. Parasternal short axis view showing a D-mal post aorta, right and anterior aorta and left and posterior pulmonary artery. We can notice that the portion of the intramural coronary artery is between the aortic and pulmonary artery sinus, and the wall of the ascending aortic aorta is shared with the wall of the coronary arteries. This sharing of the wall between the coronary artery and the aorta and the course between the aorta and pulmonary artery should be documented for the diagnosis of intramural left coronary artery. When we were discussing the great artery relationship, we mentioned that the side-by-side great artery relationship with the aorta on the left side and pulmonary artery on the right side is extremely rare in patients with transposition of great arteries. In this parasternal short axis view, we can notice that the aorta and pulmonary artery are side by side. The aorta is located to the left of the pulmonary artery. This great artery relationship is very, very rare. We can also notice that the anterior facing sinus giving off both the left coronary artery and the right coronary artery, both the coronaries arise as two separate vessels from the same anterior facing sinus. The posterior facing sinus does not give off any blood vessel at all. Whenever a transposition is associated with the usual pattern of great artery relationship, wherein the aorta is right and anterior and the pulmonary artery is left and posterior, the coronary artery origin will in most of the cases be the usual pattern, where the left coronary artery is arising from the left facing sinus and right coronary artery is arising from the right facing sinus. All the coronary artery abnormalities that were described, like single coronary arteries, intramural coronary arteries, inverted coronary arteries, are more and more common whenever the great artery relationship is not D-mal post aorta. In patients who have side-by-side great arteries, in patients who have direct anteroposterior great arteries, in patients who have L-mal post aorta, very often the coronary patterns will be different. About 1/4 of patients with transposition of great arteries may have some form of left ventricular outflow tract obstruction or pulmonary stenosis. The obstruction can be at subvalvular level or valvular level. In transposition with intact ventricular septum, the LVOT obstruction is often dynamic and hemodynamically is not very significant. It is due to the leftward bulging of the basal portion of the interventricular septum towards the left ventricle in systole. In this apical view, we can notice a large subpulmonary VSD, a hypoplastic pulmonary annulus, and hypoplastic subvalvular pulmonary area. Very often, significant LVOT obstruction is seen in association with large ventricular septal defects in TGA. Due to hypertrophy of the muscle bundles in the subvalvular area, there is a significant subvalvular LVOT obstruction in this patient. We can also notice that there is a large subpulmonary ventricular septal defect, and flows in the subpulmonary ventricular septal defect are from right ventricle to left ventricle. In this example shown, the right ventricle giving off the aorta and left ventricle giving off the pulmonary artery are clearly shown. There is no narrowing in the subvalvular area. However, the pulmonary valve is doming. It's an indicator of valvular pulmonary stenosis. On a color Doppler interrogation, we can notice that the pulmonary stenosis is confined to the valvular level. There is no narrowing in the subvalvular left ventricular outflow tract. We can also notice that the left ventricular free wall thickness is adequately maintained and there is no intraventricular septal defect. This is another example of a patient with a high muscular ventricular septal defect, again with a valvular pulmonary stenosis. There is no subvalvular narrowing. In most of the cases with valvular pulmonary stenosis, we will notice that the pulmonary valve will be bicuspid with commissural fusion. In some of the transposition with a large subpulmonary VSD, there can be a malalignment of the coronal septum. The coronal septum will be deviated posteriorly towards the subvalvular pulmonary outflow tract, and the aorta will seem to override. In this example, the aorta overrides the ventricular septal defect, and about 20% of the aortic annulus is committed towards the left ventricle. This posterior malalignment of the coronal septum is another cause of subvalvular pulmonary stenosis. A color flow Doppler interrogation shows that there is a significant flow turbulence at the region of subvalvular LVOT where there is a posterior deviation of the coronal septum. Sometimes the left ventricular outflow tract obstruction can be caused by accessory right AV valve tissue which protrudes through the ventricular septal defect towards the LVOT. The higher pressure in the right ventricle will cause a movement of the accessory right AV valve tissue into the ventricular septal defect, thereby causing an obstruction to the flow of blood in the subvalvular LVOT. These accessory subvalvular right AV valve tissues could be another reason for pulmonary stenosis. In this subxiphoid short axis sweep, we can notice that the intratrial septum is intact. There is a large subpulmonary VSD, significant subvalvular narrowing in the left ventricular outflow tract, and this is causing a severe subvalvular pulmonary stenosis. In transposition with intact ventricular septum, the mechanism of left ventricular outflow tract obstruction is different. It is due to a dynamic narrowing of the left ventricular outflow tract caused by systolic anterior motion of the mitral leaflet. The interventricular septum bows towards the left ventricular outflow tract and increases the left ventricular outflow tract gradient. In this subxiphoid coronal view, we are able to show how the interventricular septum bows into the left ventricular outflow tract, even though in this particular example there is no left ventricular outflow tract obstruction. However, in the second example, from the apical four-chamber view, we can notice that there is a dynamic left ventricular outflow tract obstruction caused by the septal bulge. The septal bulge is because of right ventricular pressure being higher than the left ventricular pressure. It's associated with systolic anterior motion of the anterior mitral leaflet, a hypercontractile left ventricle, and this dynamic left ventricular outflow tract obstruction can lead to gradients even as high as up to 60 millimeters of mercury. In this subxiphoid short axis view, again we can notice the dynamic left ventricular outflow tract obstruction caused by a combination of the septal bulge into the left ventricular outflow tract and systolic anterior motion of the anterior mitral leaflet. To summarize the causes of left ventricular outflow tract obstruction in a patient with transposition of great arteries, when there is a large ventricular septal defect, it may be due to subvalvular muscular hypertrophy. It may be due to posterior deviation of the coronal septum in a malaligned VSD. It may be due to accessory right AV valve tissue that is protruding into the left ventricular outflow tract through the ventricular septal defect. It may be due to valvular pulmonary stenosis, which very often is caused by a bicuspid pulmonic valve, or it may be primary pulmonary annular narrowing. In the presence of intact ventricular septum, it's often due to a dynamic narrowing caused by systolic anterior motion of the anterior mitral leaflet associated with a septal bulge due to high right ventricular systolic pressure and low left ventricular systolic pressure. So far we discussed about the reasons for left ventricular outflow tract obstruction. LVOT obstruction in TGA is almost always in the form of coarctation of aorta. This can either be due to a subtle isthmus narrowing or sometimes can be very severe with significant coarctation. This is a suprasternal view of a newborn infant who had transposition with ventricular septal defect. We can notice a mild diffuse isthmic narrowing. There is not much of flow gradient across this narrowed isthmus. However, the isthmus is narrow. In some patients, it can be a very severe post-subclavian coarctation. Here we can see a normal flow up to the isthmus, and then there is a very tight narrowing causing a severe coarctation of aorta. Right ventricle is of significant importance in transposition of great artery because it serves as the systemic ventricle till a definitive surgery is completed. The right ventricle can be dysfunctional due to its inability to sustain the systemic circulation, and in some patients it can even be hypoplastic. In almost all transposition of great arteries, the right ventricle will be hypertrophied because it supports the systemic circulation and sustains the systemic pressures. In rare instances, the true right ventricular cavity may be very hypoplastic. There is an associated tricuspid valve hypoplasia also. When we compare the tricuspid valve annulus to the mitral valve annulus, there is a significant hypoplasia of the tricuspid valve associated with hypoplasia of the right ventricle. In some instances, the right ventricular systolic contractility may be low due to significant hypoxia. Hypoxia may lead to myocardial dysfunction. When there is a right ventricular systolic dysfunction, there will be a dilatation of the tricuspid annulus resulting in mild to moderate functional tricuspid regurgitation. Assessment of tricuspid regurgitation Doppler velocity will give an estimate of the systemic aortic systolic pressures. When there is a right ventricular systolic dysfunction, this will result in elevation of the right atrial pressure, and that will manifest as hepatic venous and inferior vena cava congestion. We can notice that there is very minimal inspiratory collapse of the inferior vena cava, which is a hallmark of elevated right atrial pressures. There are some peculiar associations of transposition of great arteries. One such association is the left juxtaposition of right atrial appendages. Normally, the right atrial appendage and the left atrial appendage appear on either side of the great arteries and project anteriorly. However, when there is a left juxtaposition of right atrial appendage, the right atrial appendage courses all the way to the left, posterior to the great arteries, and emerges on the left side of the great arteries. This subxiphoid coronal view shows the left juxtaposition of the right atrial appendage, and the color flows show that it is a bidirectional flow into and out of the appendage. It's very important to document the presence of this juxtaposition of atrial appendage before balloon atrial septostomy. If you don't recognize this abnormality, the septostomy balloon catheter may be passed in from the right atrium into this left juxtaposed right atrial appendage and subsequently inflated and pulled back. This will just result in laceration of the left juxtaposed right atrial appendage causing injury to the heart. We need to identify this abnormality before a balloon septostomy. Yet another echocardiographic abnormality that can be detected in patients with transposition of great arteries will be the dilated aortic collaterals from the descending thoracic aorta. This is a zoomed view of the parasternal short axis where the descending aorta is seen to give off large bronchopulmonary collaterals. Transposition of great arteries is normally associated with normal sized or larger branch pulmonary arteries. Very rarely there can be branch pulmonary artery narrowing, very often in the region where the ductus gets inserted. This is a patient with a L malpost aorta. We can see the left and anterior aorta. The pulmonary artery bifurcation is shown. While the right pulmonary artery is very well developed, the left pulmonary artery in its origin is narrowed. The origin narrowing of the left pulmonary artery may be in close relation to the insertion point of the ductus arteriosus. When we do a color Doppler interrogation, we identify that the ductus is exactly inserting in the place where there is a left pulmonary artery ostial narrowing. The management of transposition of great arteries depends on adequacy of the intratrial communication, presence or absence of a ventricular septal defect. When there is an intact ventricular septum, the main aim is to ensure adequate intercirculatory mixing at the level of atria till definitive surgery is completed. In profoundly hypoxemic neonates with an inadequate intraatrial communication, small patent foramen veil, a balloon septostomy is performed to improve the hypoxia. Prostaglandin E1 infusion may sometimes keep the ductus patent and is another alternative to tide over the time period till definitive surgery is completed. Performance of balloon atrial septostomy today is very often carried out in the neonatal ICU. We can identify on a subxified coronal view the passage of the catheter through the foramen veil into the left atrium. Performance of this procedure is entirely guided by echocardiographic guidance when it is done in the neonatal ICU. Once the catheter is in position, the balloon is inflated to its full diameter and the inflated balloon is confirmed to be in the left atrium before it is being pulled back into the right atrium. Once the balloon position is confirmed to be in the left atrium, it is quickly pulled back into the right atrium and the inferior vena cava so that the septum is torn. Post-septostomy, echocardiogram will confirm an adequacy of the tear of the intraatrial septum and adequacy of the intraatrial communication. A bidirectional flow across the torn intraatrial septum will indicate adequate intercirculatory mixing. When we view from the apical four-chamber view, we can identify the torn septum and the large intraatrial communication that has been created by the balloon septostomy. The definitive surgery in transposition of great arteries is arterial switch operation. The main pulmonary artery and the ascending aorta are transected and switched across. The coronary buttons are harvested from the aorta and transferred to the neo-aorta. The pulmonary arteries are usually brought anterior to the aorta in the form of a Lecomte's maneuver. However, in patients who preoperatively had side-by-side great arteries, sometimes this step may not be necessary. Important surgical considerations before an arterial switch operation will be to find out the preparedness of the left ventricle and the need for retraining of the left ventricle, presence and location of a ventricular septal defect, and presence of a PDA. Presence or absence of significant arch obstruction which will need surgical repair, and the coronary artery abnormalities. When transposition of great arteries with intact ventricular septum are associated with fully regressed left ventricular retraining strategies are adopted. The aim of a left ventricular retraining strategy will be to give both a volume overload and pressure overload for the left ventricle. It can be done by a pulmonary artery banding associated with a BT shunt. The pulmonary artery banding will increase the left ventricular systolic pressure, thereby resulting in left ventricular pressure overload. When it is combined with a BT shunt, the BT shunt will result in an aorta to pulmonary artery flows through the shunt, increasing the pulmonary venous return and increasing the left ventricular volumes, and this will result in a left ventricular volume overload. The same left ventricular pressure and volume overload can be achieved by doing a ductal stenting also. In the ductal stenting strategy, the closed ductus is either recanalized and opened, or a very restrictive tiny ductus is balloon dilated and stented. After a large ductal stent is in place, the aorta transmits its systolic pressure onto the pulmonary artery through the large flows through the ductal stent. Very often, a 4 mm stent is taken to stent the ductus in order to improve the pressures in the pulmonary artery. The aortic pressure, when it is transmitted onto the pulmonary artery, will result in pulmonary hypertension and result in pressure overload to the left ventricle. The shunt from aorta to pulmonary artery increases the pulmonary venous return and the left ventricular inflow, thereby resulting in left ventricular volume overload. In this subxifoid short axis view, we can notice a large 4 mm stent across the ductus arteriosus, causing a continuous flow of blood from the aorta into the pulmonary artery. In subxifoid short axis view without color, we can notice the position of the ductal stent, the parallel relationship between the aorta and the pulmonary artery, and we can notice the septal position. The interventricular septal position is in the midline, indicative of similar pressures between the right ventricle and the left ventricle. We can also notice the thickness of the left ventricular free wall comparable to the thickness of the right ventricular free wall. When we do a color Doppler interrogation in this subxifoid short axis view, we can notice the continuous flow through the ductal stent from the aorta into the main pulmonary artery. Immediately after the ductal stent, the left ventricle may still not get adequate pressure and volume overloading, and so the interventricular septum may still be bowing into the left ventricle. However, as days pass on, the continued pressure and volume overload caused by the ductal stenting will progressively result in more and more thickening of the left ventricular free wall. After a few days, the left ventricular free wall becomes quite thick and the left ventricular volume also becomes roomy. This is a parasternal long axis view showing the well-developed left ventricle, the pulmonary outflow tract, and the ductal stent is seen in the roof of the main pulmonary artery. In this parasternal long axis view on color Doppler echo, we can notice an abundant flow from the aorta into the pulmonary artery through the ductal stent, and this results in a volume and pressure overloading of the left ventricle, thereby retraining the left ventricle. The suprasternal long axis view of the aortic arch shows the position of the ductal stent. Performing a pulmonary artery banding with BT shunt is the surgical method of retraining the left ventricle. In the apical four-chamber view, we can see a tight band in the middle of the main pulmonary artery, which gives to pressure overload of the left ventricle. In this parasternal long axis view, we can notice the position of the pulmonary artery band. The echogenic two lines in the middle of the main pulmonary artery are indicating the site of the pulmonary artery band. When we do a color flow imaging, we can notice the tight obstruction offered by the pulmonary artery band. We can see a continuous color flow distal to the band due to the continuous flow of blood from the aorta to the pulmonary artery through the BT shunt. The parasternal short axis view shows a right and anterior aorta, left and posterior pulmonary artery, the pulmonary artery band in place, the branch pulmonary arteries with continuous blood flow in the branch pulmonary artery due to the flows through the BT shunt. While we are doing an echocardiographic follow-up of a patient after an arterial switch operation, we should find out whether there is any right ventricular outflow tract or left ventricular outflow tract obstruction, which is common at the region of anastomotic site. Branch pulmonary artery narrowing can happen in the place where the Lecomte maneuver has been done. There will be progressive neo-aortic regurgitation and neo-pulmonary regurgitation. There will be a neo-aortic root dilatation. Residual VSDs may be noted. If there are any coronary anastomotic abnormalities that will result in ventricular dysfunction, we'll often need an angiogram for confirmation of diagnosis. Left ventricular systolic function will show impairment if there is any coronary compromise. Parasternal long axis view after an arterial switch with VSD patch closure shows the patch in the subpulmonary location. The left ventricle is now pumping into the neo-aorta and the right ventricle pumping into the neo-pulmonary artery. After the arterial switch operations, there can be milder degrees of neo-aortic regurgitation and milder degrees of left ventricular outflow tract obstruction. In this example, a previously bicuspid pulmonary valve has now become the aortic valve, and that is causing a mild flow turbulence in the left ventricular outflow tract. In this apical view with an anterior sweep, we can notice both the great arteries. After the arterial switch and VSD closure, the patch is seen, there is no residual VSD, and both the outflow tract are showing mild turbulence. A continuous wave Doppler interrogation across the left ventricular outflow tract shows a mild LVOT gradient and a mild aortic regurgitation. Supravalvular narrowing at the region of the anastomotic site after an arterial switch operation is more commonly seen in the pulmonary outflow tract. This is an apical four-chamber view. Progressively with an anterior sweep, we can notice a normal left ventricular outflow tract, but a severe supravalvular main pulmonary artery narrowing. A continuous wave Doppler interrogation across that severe supravalvular pulmonary narrowing showed a gradient of close to 75 millimeters of mercury. After performance of the Lecomte maneuver, where the branch pulmonary arteries are brought anterior to the neo-aorta, the pulmonary arteries may get stretched across and some of the branch pulmonary arteries may get narrowed. In this high parasternal short axis view, we can notice after the Lecomte maneuver, both the right pulmonary artery and left pulmonary artery origins are narrowed and they show a flow turbulence. A magnified view of the branch pulmonary artery shows that there is a substantial narrowing of the origins of the left pulmonary artery after this LeCount maneuver. This is due to stretch of the left pulmonary artery. We can notice that both the right pulmonary artery and left pulmonary artery origins are showing gradients more than 60 millimeters of mercury in this situation. We need to carefully follow up these patients for finding out whether they will go into right ventricular failure. When VSD closure is done as a part of arterial switch operation, a careful analysis of the VSD patch should be done to find out residual ventricular septal defects. Tiny hemodynamically insignificant residual VSDs may not be of any great consequence. However, we should try to identify if there is any large residual ventricular septal defects. This parasternal short axis view shows a small residual VSD with a small flow from the left ventricle into the right ventricle. Today, Senning's operation or atrial switch operation is done in very late presenters where the left ventricle cannot be drained. The pulmonary veins are baffled towards the tricuspid valve and the systemic veins are baffled towards the mitral valve. An apical four-chamber view shows the dilated right ventricle and the dilated right atrium. The pulmonary veins have been baffled towards the tricuspid valve. We can appreciate a wide pulmonary venous baffle in this apical four-chamber view. Ideally, the pulmonary venous baffle should have laminar flows without any turbulence, as shown in this example. In the same way, the systemic venous baffle draining the superior and inferior vena cava blood towards the mitral valve should also have a laminar flow. On a three-dimensional echocardiogram, when we crop off the right ventricular anterior free wall, we can see the large unobstructed pulmonary venous pathway entering towards the tricuspid annulus. In this apical view, we can notice the large pulmonary venous baffle, unobstructed flow towards the tricuspid valve. The pulmonary venous baffle is shown with a small white arrow. Similarly, on a 3D echo, we can also notice the systemic venous pathway shown with the small arrow. The systemic venous blood will be routed through this systemic baffle towards the mitral valve. We can appreciate the combined systemic venous baffle pathway very clearly in this view shown by an arrow towards the mitral valve. When we follow patients after sending surgery, baffle leaks or baffle obstruction can be noted. Right ventricular systolic dysfunction and tricuspid regurgitation will almost always be seen after a few years after sending surgery. The most serious problem after sending surgery will be the pulmonary venous baffle obstruction. Here we can find the pulmonary venous baffle is tightly obstructed due to fibrosis of the pericardial patch that has been used, causing a severe pulmonary venous hypertension. Very mild pulmonary venous baffle obstructions with mean gradients of around 4 millimeters of mercury, as shown in this example, will not lead to any hemodynamically significant pulmonary venous hypertension. To summarize on echo evaluation of a transposition of great arteries, we should start evaluating the intratrial septum for adequacy of the intratrial communication, interventricular septum for the location and number of ventricular septal defects, the great artery relationship, presence or absence of left ventricular outflow tract obstruction and arch obstruction, and the abnormalities in the coronary artery origin.